Good afternoon, and welcome to the National Organization for Tardive Dyskinesia's first webinar, Treatments for Tardive Syndromes. Uh, my name is Tanya Zivin. I'm a volunteer at NOTD. I do not have TD, but my 15-year-old daughter does, and she's actually recovering. Before we begin, I would like to let you know that some housekeeping rules. First of all, this presentation is being recorded, and a recording will be emailed. An email with a link to the recording will be sent to you probably by tomorrow. You can also, we have a questions box if you look in your control panel. You may ask questions anytime during the webinar, and we will try to address them during the Q&A session at the end of Dr. Factor's presentation. Please limit your questions to, please don't talk about your personal medical issues. Please try to keep your questions as general as you can so everyone can benefit. And if you are having trouble with the audio using your computer, you can dial in by phone. You can check your join email for dial-in instructions. Now I would like to introduce to you Kathleen Shea, who is the president and founder of the National Organization of Tardive Dyskinesia. Kathleen, can you share your webcam and microphone, please?
Yes, hi everybody. I'm Kathleen Shea. We're so happy you joined us today. I wasn't sure if I would be able to join you or even have power as we were in the path of Hurricane Ada last night. Thankfully for all of us, the storm weakened substantially and made landfall about an hour north. And I'm having a little difficulty with speech today, so please forgive me. So now let me introduce to you our presenter, Dr. Stewart Factor. Dr. Factor is the director of the Movement Disorders Program and Vance Lanier Chair of Neurology at Emory University School of Medicine. He is past chair of the Movement Disorders section of the American Academy of Neurology. He has edited 4 textbooks on movement disorders, as well as authoring over 300 peer-reviewed articles. He also has a special interest in Tardive syndrome research. So without further ado, we welcome Dr. Factor.
Hi, everyone. Thank you, Kathleen, very much. And thank you for the invitation to participate in this. Kathleen and I were talking about how we were making history because this is the first presentation for the National Organization of Tardive Dyskinesia. As Kathleen said, I'm at Emory University. I'm a neurologist. I've been at Emory for about 15 years. And I've been very interested in tardive dyskinesia since the beginning of my career, which goes back to the late 1980s. And one of the books that I published back in 2005 was a book on drug-induced movement disorders that I co-edited with 2 other neurologists who were also interested in drug-induced movement disorders. And I'm just glad to be here to talk to you today and focus more on treatment of tardive dyskinesia and just give you a sense of my thinking, how I think about tardive dyskinesia and how we approach the treatment using a variety of different options. Let me see if I can move the slides. Okay. So I'll just start with a little introduction of things that most of you already know, just to sort of tee things up for the treatments. Tardive dyskinesia or tardive syndrome, as you know, is a chronic movement disorder that's caused by medications. So it's what we call an iatrogenic disorder. And it's caused by medications that block dopamine receptors in the brain. And there are 2 groups of drugs that do this. One group is a group that are used for psychiatric disorders, mostly antipsychotic drugs, but some of them are used for depression as well. And then there's a group of disorders used for gastrointestinal problems, and they include things like Phenergan and Reglan or Compazine or others. Some people have been exposed to those and get these syndromes. The clinical characteristic of it is this movement that occurs around the face involving the tongue and the jaw and the lower face, although it can affect almost any body part. And we've certainly seen that in patients. And usually patients have to be exposed to these drugs for months, although the older you are, the shorter the exposure needs to be. And many neurologists, such as myself, have actually seen people with few exposures who still develop the syndrome, even 1 or 2 exposures. Trying to get the slides to move. Anya, can you help me?
Yeah, sorry. Okay.
So I'll just say next slide, okay? Will that work?
Yes, that will work. Sorry.
That's okay. So, so this is a slide to just show you why I tend to use the term tardive syndrome, and actually the profession is now moving in this way. It used to be that the term tardive dyskinesia was a broad term used for all movement disorders. But now the term tardive dyskinesia is used to describe that classical facial syndrome as shown up here on your left. And tardive syndrome is the term that we use to encompass all of these disorders. And you can see from this listing that most of them are movement disorders. There's tardive dystonia, there's tardive akathisia, there's tardive tics or Touretteism, tardive chorea, and many others, as you can see. And there are even many syndromes that involve sensory phenomena such as pain and other sensory disorders. So that's where the term tardive syndrome comes from. Next slide. And then next. So I'm going to give you some, that's great. Thank you. So I'm going to give you some terms that we use to just explain them. So dyskinesia is a term used for abnormal involuntary movement. It's just a general term, can be any kind of movement. And chorea is a disorder that is random and spontaneous. It comes from the word choreography, which is dancing. And when it's very severe, the person looks like they're flinging parts of their body. We call that ballism, seen in red there. Dystonia is more of a syndrome where you get sustained muscle contraction and abnormal postures. And tics, which are seen in Tourette syndrome, are brief, rapid movements that can appear to be purposeful, but are not. And they too can have an urge or a sensory phenomenon associated with them. These can be very complex movements or very simple movements like eye blinking. And then finally, stereotypy are these involuntary coordinated pattern movements like bouncing your legs up and down or rocking your body back and forth. And if they're associated with an urge to make those movements or an inner sense of restlessness prior to doing those movements, that's called akathisia. And so classical tardive dyskinesia, tardive dystonia, and tardive akathisia are the most common forms that we see. Next slide. So the cause, as I mentioned, are these drugs that block dopamine receptors. And the most important receptors that are blocked are D2 receptors. And most of the drugs that are available to treat schizophrenia and now to treat some of the drugs to treat depression and those gastrointestinal drugs I mentioned are strong blockers of dopamine D2 receptors. And there's a discussion about how tightly they bind to the receptors and what role that plays in causing the tardive syndrome. it's believed that drugs that tightly bind to the receptor are the ones most likely to cause tardive dyskinesia. And there are some drugs, some of the more recent drugs, that tend to bind more loosely, and they have a lower risk of causing tardive dyskinesia. And I'll talk a little bit more about that in a second. What results, though, from this tight binding of D2 receptors is a persistent increased sensitivity of those receptors and what we call a hyperdopaminergic state. So increased dopamine. And there's actually a good other example of a hyperdopaminergic state causing involuntary movements, and that's seen in Parkinson's disease, where patients, if they're treated with too high a dose of levodopa, they actually develop a choreic movement that in some ways can look a little bit like tardive dyskinesia. There are a variety of other theories of what else goes wrong in the dopamine system, and I don't really want to get into those right now, but suffice it to say, it's really a hyperdopaminergic state that leads to this movement disorder. Next slide. So this is an old, a slide from an old paper, and I just wanted to make the point about this loose binding versus tight binding. If you look at the top of the chart up here, it's a listing of many of the antipsychotic drugs. And this is all done with imaging, PET or SPECT imaging. And there's an area in here between 60% and 80% occupancy of the receptor that shows an antipsychotic effect. So if they have a lower effect, they might not be able to treat psychotic symptoms. But the ones that treat at the higher level, closer towards 80, are the ones that have the highest risk of causing tardive syndromes. And then the ones sort of at the end here that have a lower binding, and they're in this region here, have much less in the way of causing tardive syndrome. And the two most important drugs in this group are quetiapine, which is also called Seroquel, and clozapine. And so these are the two drugs that are least likely to cause tardive syndrome. Next slide. So now on this slide, I'm not going to go into a lot of detail, but just wanted to point out that there are other theories and possible mechanisms that may occur in relation to the hyperdopaminergic state that may lead to susceptibility to tardive syndrome. And they include a variety of other neurotransmitters such as GABA and opioid and norepinephrine and serotonin and glutamate, all of which may play a role. And it's these theories that have led to the use of other drugs. And I'll show you these other drugs when we talk about treatment. Just one other thing to mention is the role of genetics. We're kind of in the infancy of studying the role of genetics in tardive syndromes, but there may be some genetic abnormalities that could lead to a susceptibility to develop tardive syndrome. And the hope is in the future, before people are treated with such drugs, they can be tested to see what their risk might be. Next slide. So before I get into the trials, there are two things I want to talk about that are in the literature that you should know about. The first is this thing called the Ames scale. Ames is Abnormal Involuntary Movement Scale. It was developed to measure tardive syndromes or tardive dyskinesia in particular in the 1970s. In many states, it's required that patients who are hospitalized with psychiatric disorders or followed as outpatients get an Ames score each time, or at least once a year, when they're being treated with the drugs that can cause tardive syndrome. And so this is used in many of the clinical trials, looking at change in the Ames scale as a measure of responsiveness. Now you can see that the severity part of the scale, which is what we use, has 7 parts, and it's all divided by body part. So muscles of the facial expression, lips and around the mouth area, jaw movements, tongue movements. You could see the emphasis is on the facial area. and then a score for arms, legs, and trunk, which includes neck, shoulders, and truncal area, the mid part of your body. Each of these is scored 0, no movements, to 4, severe movements. Next slide. Now, the other thing I wanted to talk about is how studies are evaluated. And so what you're going to hear me say and what you're going to see on my slides is that there are certain levels of recommendation and there are certain classes of studies. And all of this is based on not how good the drug is, but how good the study is. So if you see a drug that has a level A recommendation, which is the highest recommendation, it doesn't mean it's better than all the other drugs. It just means that the studies were designed better and were more likely to show you a responsiveness than maybe a drug that has level B or C recommendation, in which the studies were just not as good. Again, it doesn't mean that the drug is better. There are very few head-to-head trials to compare different drugs. So just bear that in mind. And in recent years, there's been an increase in interest in tardive dyskinesia because more drugs have become available. And as you know, in 2017, the first drugs FDA approved specifically for tardive dyskinesia were approved and became available. In 2013, there was an evidence-based guideline to look at what drugs are useful. And then this was updated in 2018 after those new drugs were FDA approved to update what the evidence shows. And much of what I'm going to show you when I talk about my approach to treating it relates to how good the evidence is. Next slide. So just very quickly, the level of evidence for the type of study, the most important drug study, the class 1 study, is a randomized, double-blind, actually sometimes we use the term masks, control trial that compares the drug to either an active comparator or placebo. And these studies are the best studies. They have the least amount of bias, and they follow all of these different requirements here on the bottom. So those are the best studies that we have. Next slide. And there are other levels of classes for the studies. So class 2 is a randomized double-blind study, but doesn't meet all 4 criteria that I showed you there. Class 3 are other controlled trials like crossover trials, which are very common in psychiatric studies, where a patient is treated with either a drug or placebo, and then after a number of weeks they cross over, and then the placebo group is on active and the active group is on placebo. And then class 4 are studies that have no randomization and no control to them. It's just people treated openly to see if they would respond to the drug. Next slide. And then the level of recommendation here relates to how many of the different types of studies that they have. And what you need to remember is a level A recommendation means they had 2 class 1 studies. And level U just means that the data available is insufficient to make a recommendation. Next slide. Okay, so now after saying all of that, we'll talk about treatment now. And I follow this paradigm that actually I recently published in a paper earlier this year. And so generally what we do when we treat patients is the first thing, of course, is to make an appropriate diagnosis. And then the second step is to try and remove the drug that's causing the disorder. Now, sometimes people can't come off of that drug, so we sometimes recommend that people go on a less potent drug or a drug less likely to cause tardive syndrome, like clozapine or quetiapine. And so those are always the first steps. And some people will get better just by doing that, and you don't need to actually treat the movements. But there's a substantial portion of patients that continue to have the movement disorder after they've either removed the drug or switched to a lower potency dopamine blocking drug. In which case then I have a I have an approach that includes 3 tiers of oral drugs and then some additional treatments that I'll talk about, including botulinum toxin therapy and even brain surgery, deep brain stimulation surgery. And we're going to go through each tier, and then we'll come back to this at the end. So next slide. And then we can skip this slide because I already just talked about this. And so this is the first tier of drugs. And the reason these are the first tier of drugs is because the deutetrabenazine and the valbenazine are the newly approved drugs for TD. And these are the only drugs that are actually FDA approved for that purpose. Tetrabenazine is approved in the United States for the treatment of Huntington's disease, which has chorea, but not for TD specifically. Next slide. So tetrabenazine actually only has a level C recommendation, but it's been around for several decades, even though only approved in the United States since 2008. But valbenazine and deutetrabenazine have level A recommendations and really represent the first choice of drug. So just to tell you what these are all VMAT2 inhibitors. VMAT stands for vesicular monoamine transporter inhibitor. So I'm not sure if you can see on this slide here, but this is a dopamine neuron here down on the bottom right. And the blue dots are dopamine. And what normally happens is dopamine is taken up into the cell, or it's created anew within the cell. And then VMAT takes it up and puts it in a vesicle. The vesicle actually protects it and allows it to be released into the synapse to act upon the postsynaptic cell. Now, dopamine, when it's not protected, is broken down by an enzyme called monoamine oxidase. Under normal conditions, there's a balance between that which is taken up into the vesicle and that which is degraded. VMAT2 inhibitors to the far right here block the uptake into the vesicles. So most of the dopamine is then metabolized by MAO, and then the cell gets depleted of dopamine. And so you get, that's why these are called dopamine depleting drugs, because they actually remove all the dopamine from the synapse. Next slide. Now, there are 2 very small studies of tetrabenazine, and I'm just going to mention one of them to you. This one was published in 1999 by a group in Texas. It was very small, only 19 patients, and actually it was not a double-blind study. All 19 patients were treated with the drug, but what they did was they videotaped them before and after treatment, and they had blinded raters review the video, give them an AIM score, and what they were able to show was there was about a 50% improvement in patients with this drug. So that demonstrated what we kind of knew all along, was that tetrabenazine would be able to improve tardive syndromes. Next slide. The problem with tetrabenazine is lots of side effects, troublesome side effects. About nearly 30% in a large study had Parkinsonism, looking like Parkinson's disease. 25% had drowsiness and fatigue, and about 10% developed akathisia, which is a very troublesome motor restlessness, as I mentioned before. So lots of side effects to tetrabenazine. Next slide. So deutetrabenazine, also called Austedo now, and valbenazine, also called Ingrezza now, were developed to try and maintain the effectiveness of tetrabenazine, but decrease the side effects associated with that. So valbenazine is a metabolite of tetrabenazine. It does not have this really high peak level in the blood of tetrabenazine. And by blunting that peak, there are fewer side effects, and it has a long half-life, so you can use it once a day. And Deutetrabenazine or Austedo was the same in that it actually blunted the peak effects and has a longer half-life than tetrabenazine and could be used twice a day. Tetrabenazine is generally used 3 times a day. So safer drugs and still effective in treating these syndromes, although there's been no comparative study looking at which would be more potent in decreasing the movement disorder. Next slide. So I'll just mention one study for each of these 2 drugs. So for valbenazine first, or Ingrezza, one of the studies was called Connect 3, and it compared placebo to 40 milligrams to 80 milligrams in a randomized controlled trial. This study was 6 weeks in length, and so the patients were placed immediately on the drug level that they were going to be placed on. And the primary outcome measure was an improvement in that AIMS severity scale that I showed you before. And again, the measure of it was done by blinded raters who reviewed videotapes of the patients before and after treatment to see how they did by measuring their scores. When those videos were shown, they were randomized, so we didn't know if it was their first video, their last video. We just didn't know which video it was. Next slide. So what was found in these studies was that the 40 milligram, so the orange line is placebo, the dotted line is 40 milligrams, and the solid line is 80 milligrams. And it was shown there was a dose response effect. 40 milligrams was better than placebo, and 80 milligrams was better than 40 milligrams. And there was about a 3.5 point improvement. And a substantial number of the patients on 80 milligrams, that's the dark green here, had a greater than 50% improvement in their AIMS score. So a very potent response. Next slide. For deutetrabenazine or Austedo, one of the studies was called the AIMS-TD study, the AIM-TD study. And what they did was they compared also different doses to placebo. So placebo, 12 milligrams per day, 24 milligrams per day, 36 milligrams per day. And this was a 12-week randomized controlled trial. And the AIM scale was scored in the same way, using experts to review videos in a randomized fashion and to come up with scores. Next slide. And this is a fairly similar looking slide that shows that this black dotted line is placebo, the green line is 12 milligrams, the blue line is 36 milligrams, the orange line is 24. And what you can see is there's a dose response. 12 milligrams gives you a modest improvement, but both 24 and 36 milligrams showed a very significant improvement in patients. So very similar, about over 3 points improvement, just like the Ingrezza showed. Next slide. So this slide, just, yeah, click it again, that's good. So what this slide shows, no, I'm sorry, go back, yep. What this slide shows is if you stay on the drug for a long time, this is the Austedo study. It showed that actually patients can maintain their response for 2 years. And this is the valbenazine trial, which showed that the improvement can be maintained for a year. And this study was unique in that they then washed people out of the study over a period of a few weeks. And what they found was the tardive syndrome actually returned. So what this shows is that these drugs don't cure tardive dyskinesia. What they do is they control the symptoms. They're symptomatic treatments. Next slide. And then these are the side effects. And the one thing I want to point out is that you don't see Parkinsonism in these 2 lists, which is good. It's much less with these 2 drugs than with tetrabenazine in those prior studies. You do still see a little akathisia in these Probably somnolence is the one that we see the most in practice, but these are other things that have been seen in patients as well. Next slide. So what if these drugs don't work? And there is a pretty good portion of patients who take these VMAT2 inhibitors and they either don't get a response or they don't get a good response, or they have side effects and they can't tolerate it. So then we move to these second tier drugs, and these are all either level B or level C evidence. They don't have as good a clinical trial. They're on multi-center trials like the valbenazine and the Austedo do. So let me go through these drugs very quickly with you. Next slide. So amantadine is an old drug that was developed in the 1960s, actually to treat the Asian flu, but was found to be effective in treating Parkinson's disease. And then later on in the 90s, they found it actually improved the levodopa-induced dyskinesia. And so several studies were thought that it might be useful in treating tardive syndromes. In the very early days, there were some reports of that occurring in small open trials and case reports. And then in 1973, there was a negative double-blind study. And then there were 3 positive double-blind studies that came out after that. And I'll show you 1 or 2 of those. Next slide. So this one is from 1997. This was a study on 16 patients. They had an 18-week double-blind study, which was a crossover. So it's actually a class 3 type trial. They used 300 milligrams, and they used the AIM scale to measure responsiveness. And what they found overall in the group was that there was a 15% improvement in AIMS. It was a modest effect. Next slide. And what this table shows, just very briefly, I know it's hard for you to see, but so the responsiveness varied from 10% improvement to 40% improvement, and 10 of the 16 total patients responded. So some reasonable, helpful response in a good portion of the patients. Next slide. The most recent study was from 2010. This was a larger study, 22 patients who had schizophrenia and also had tardive dyskinesia, and they were treated with a little higher dose, 400 milligrams per day. And they again used the AIM scale to measure response. Next slide. And I just want you to look at, A here. This is the total AIM scale score, and black is placebo and slashed here is amantadine. And you can see that there was a very significant improvement over placebo in patients. So again, another study showing that amantadine could be effective, perhaps not as effective as the VMAT2 inhibitors, but effective nevertheless, and reasonably well tolerated. Next slide. And these were the side effects. Insomnia, constipation can be a troublesome one, and occasionally dizziness. Next slide. So now we'll talk about clonazepam. Clonazepam is a benzodiazepine. It's like Valium, but it's longer acting. And it came out in 1975, so it's been around a long time. It's used as a tranquilizer, but also to treat seizures, anxiety and panic disorder. It has a very quick onset and lasts anywhere from 6 to 12 hours. And there have been numerous attempts to study this drug in tardive syndromes. And I'm just going to show you one, probably the best study that was done for this. Next slide. So this study was published in 1990, and it was a double-blind, placebo-controlled, randomized trial. So it was a class 3 trial because of the crossover. There were 19 patients, and they used the AIM scale to measure improvement. Next slide. And I just draw your attention to this graph here, which shows here is placebo, and then here is the active drug, and then here is placebo again. And you can see a number of patients had a very dramatic improvement, and others had a lesser improvement. And one of the things they show that other studies haven't shown is that some patients have dystonia, and these are the open circles, a little hard for you to see. And then some have classical TD, those are the solid black circles, and both groups of patients improved. What they were able to show was the dyskinesia improved by about 27%, whereas the dystonia improved by over 40%, which is a pretty substantial improvement with this drug. Next slide. I'm sorry, can we go back? I just want to make one other point. One other point about this drug is that it is habit forming, and that's always a problem with these drugs. And if you try to abruptly withdraw from the drug, you can have a withdrawal syndrome associated with that. So like Valium, you have to be very careful with that aspect of it. Next slide. So the next treatment is actually an over-the-counter treatment that has shown level B evidence, and it's ginkgo biloba. You can buy that over the counter in pharmacies and in other stores. The other name for it is the maidenhair tree. That's a picture of the ginkgo tree here, the maidenhair tree. It's native to China, and almost all the studies done on ginkgo have been done in China because they use it so often. They use an extract of ginkgo, and what they found, it's a potent antioxidant drug that can be very helpful in decreasing oxidative stress in the brain. It's been used for Alzheimer's disease and a variety of other disorders, but there's no real evidence for that. But it has been recommended for these things. There is a little evidence for peripheral vascular disease and macular degeneration that it might be helpful for those. And sometimes it's advertised as a supplement for cognitive function, again, with no evidence. There was one very large study on tardive syndrome in 157 patients. It was a double-blind, placebo-controlled trial that was done. Next slide. And this is the abstract from it. I'm just going to point out a few things. They used 240 milligrams per day versus placebo. This was a very good trial. And what they found was that there was about a 2-point improvement in the Ames scale, and that 51% of the patients receiving ginkgo had a 30 to 40% improvement versus only 5% in the placebo group. So it showed fairly substantive improvement in patients with very few side effects. I should note, every patient in this study was was male. They were all under the age of 60. So we don't know how well that would work in people who are older and in women because there's no data on that. Next slide. So this is what we call a meta-analysis. There were 2 other studies using ginkgo to see if it would actually help enhance the antipsychotic effect of drugs, but they used an Ames scale to measure tardive syndromes. And what they found in all 3 studies, if you look over to the right, is that all of them showed about a 2-point or a little over a 2-point improvement in tardive syndromes. So, so this seems to show a consistent improvement. Again, the same group did all these studies, and they were all done in China. These have not been replicated in other countries, at least not yet. Next slide. So now we'll go to the 3rd tier I have a few more minutes left, so I'll try to go through this fairly quickly. I'm not going to cover all of these drugs. Many of them have only been studied in single studies. Piracetam is not available in the United States. So we'll just talk quickly about a few other drugs. Next slide. There was a very good study done with this drug, levetiracetam, which is also called Keppra. It's an anti-epileptic drug, and it has a variety of actions, including affecting vesicle function. And so there were 3 open trials that showed that it might be effective, and then a single double-blind placebo-controlled trial of a good number of patients, 50 patients, for 12 weeks. And next slide. And what this showed was this dotted line is the placebo group, and this solid line is the levetiracetam group, and there was a significant improvement by 12 weeks in tardive syndrome. The reason this is in a class B or C or level is because a lot of people dropped out of the study, and so that lowered the class and made this a level U. But it looks like Keppra can be helpful, and I've used it in some of my patients and have found it to be helpful. So certainly worthwhile trying if the other drugs don't work. Next slide. We can skip this. The main side effect is sedation. Next slide. So melatonin is a hormone released in the brain by the pineal gland, discovered in 1958. And it also is an antioxidant. You all probably know it as a sleep regulating drug. It's sometimes used for insomnia, sometimes used to treat jet lag. And we use it regularly to treat a disorder called REM sleep behavior disorder, where people act out their dreams. There's actually a prescription drug called Ramilton that works on melatonin receptors and can also be used for this purpose. And there have been several different trials done to treat this. There are 2 particular double-blind trials, and the second one from 2001, was actually pretty positive. Can we show the next slide? And so the 2001 study is the Shamir study. It was the best controlled trial, but this is a meta-analysis, again, taking the 4 best trials, anywhere from 7 patients to 39 patients, and looking at the improvement in the AIM scale. And what they actually found was anytime the line crosses this 0 line here, it means it was not a significant improvement. So none of these trials actually showed a very significant change, but a 1 or 2 point improvement, and it's been shown to be very safe. So certainly possibly worth using in patients. Next slide. Vitamin B6, people ask me about. So vitamin B6 pyridoxine has many functions in working with neurotransmitters. It also has an antioxidant effect. The problem with B6 is that it can cause peripheral neuropathy that can be permanent. So it can have toxic effects in patients. And we try to avoid using it. Probably the maximum dose one could safely use is up to about 200 milligrams per day. And there was one clinical trial using 1,200 milligrams a day versus placebo that showed improvement in the AIM scale. But again, that might be a dangerous thing to try. So we should limit its use. Next slide. And then baclofen is an old drug approved in 1977, used for muscle spasm, and it's also used to treat dystonia. And there have been 3 positive clinical trials showing its usefulness. The most recent one was in 1982, so these were very old trials, but we've used it in some of our patients and found it to be helpful. Next slide. And then I think we'll skip the next slide just for the sake of time. And propranolol is a beta blocker that has been used. It was approved in 1964 for the treatment of hypertension. It's also used for angina and migraine and essential tremor and for performance anxiety. And it has been used in tardive syndrome. In fact, I've been very interested in the use of this drug. Next slide. This slide just shows that in the 1980s, several very small studies suggested that it might be helpful. Next slide. I'm sorry, I'm starting to go a little quicker because I have more things to cover. And then we published a paper on some 40 plus patients with tardive dyskinesia, where we looked at the effectiveness of this in our practice. Next slide. And what we showed was that, and I'll just explain that a score of 3 or 2 represent moderate to significant improvement. And we showed that a majority of these patients had a significant improvement in tardive dyskinesia. We did not use the AIM scale to measure this. We just used a total 0 to 4 scale. So in our practice, we tend to use this a little more often than is probably used in general. Next slide. And just want to mention very quickly that for akathisia, tardive akathisia, propranolol actually is the treatment of choice, but 2 mild antidepressants, mirtazapine and trazodone, are specifically useful in treating akathisia. And then for tardive dystonia, anticholinergic drugs such as benztropine and trihexyphenidyl can be useful in treating dystonia, but they can make classical tardive dyskinesia worse. So you have to be very careful in relation to using these. And also using botulinum toxin is an important treatment for dystonia, which I'm going to talk about next. Next slide. And put everything onto the slide. One more. That's good. So botulinum toxin's been available since the 1980s to treat dystonia. And now there are 4 different types. There are 3 that are type A, Botox, you've heard of, Xeomin and Dysport, and then Myoblock is type B. These toxins are made by a bacteria called Clostridium botulinum, shown here in this picture. And they can be measured so that they're not, so you don't get botulism when you use it, but botulism is caused by severe muscle weakness, and we take advantage of that effect in order to treat involuntary movements. Next slide. So in the neuromuscular junction, this is the muscle down here on the bottom, and this is the nerve cell on top. Acetylcholine, which is a neurotransmitter, is usually released. That causes the muscle to contract. And so if you inject botulinum toxin into the muscle, it leaves the muscle, it's taken up into the nerve cell. It's this black thing here, that's the toxin. It gets taken up into that, released into the cytoplasm, and then blocks the connection of the vesicle with acetylcholine to the membrane. By blocking that, it blocks the release and prevents muscle contraction. That's how it causes weakness, and that's how it actually results in improvement in dystonia and other movement disorders. Next slide. I'm going to skip this. So there was one study in classical tardive dyskinesia that showed if you inject the muscles around the mouth with low doses, you can improve the involuntary movements of lips. And there have been no studies, no double-blind studies in tardive dystonia, but it's been shown in open-label studies that patients with tardive dystonia respond in exactly the same way as people with idiopathic dystonia. And so they can really get a very good response. So for those of you who haven't been injected, you get injected into the region. It takes about 4 to 7 days for it to kick in, and the responsiveness can last about 3 to 6 months. And so it works exceedingly well, but you have to have it repeated fairly regularly. And when it wears off, the movements come back. Next slide. So I just want to finish with a few quick comments about surgery. Deep brain stimulation is like a pacemaker in the brain. You place a wire into your brain. You can see it on this X-ray here. It has little electrodes on the bottom, and what you do is you turn on the pacemaker device, and it stimulates that region, changing the way your nerve cells are activating. And by changing that, it actually can alter the abnormal impulses that are causing your movement disorder and can improve the movement disorder fairly substantially. Next slide. And then click it again. So there are several targets in the brain. This is a cartoon of a slice of the brain. There are several targets that are used for tremor. The thalamus, shown here, is used for tremor, and the subthalamic nucleus here is used for Parkinson's disease. But the globus pallidus here is used for dystonia and for tardive dystonia and tardive dyskinesia. You can see the electrode in a cartoon here in the globus pallidus. That's the target we usually go for. Next slide. This is what the devices look like. These are the devices that go in your chest. They look like a pacemaker device. They can be programmed by the doctor from outside. You can even program it to some extent, or you can turn it on and off if you need to. And this is what the leads within the brain actually look like. They have different leads that you can try to see which region of the brain stimulation actually works the best. Next slide. And it's done in an operating room with an MRI scanner. This is from a picture from UCSF, but we have a similar setup. And the patient is asleep under anesthesia, and they use MRI. They take pictures and can see the location of the lead and to make sure it's in the right place for stimulation. Next slide. So there have been two recent very good trials, level B or C trials, looking at tardive syndromes with deep brain stimulation. Next slide. I'll show you one of them. So this study that was published in 2016 was in 19 patients who had GPI stimulation, globus pallidus, and they used the Ames scale, but they also used another scale called the extrapyramidal symptoms rating scale. That was really the primary measure because it has a way to measure both dystonia and classical tardive dyskinesia. And at the 6-month period, what they did was they would turn off or turn on the stimulator, and the person evaluating the patient would be blinded, so wouldn't know if they were on or off their stimulation at the time. Next slide. And so this is the double-blind measure at 6 months. You can see with stimulation on, there was about a 50% to 60% improvement in the extrapyramidal symptom rating scale, showing fairly dramatic improvement in the movement disorder. Next slide. And they followed people out as far as 11 years and found there was a continued almost 60% improvement. So it's maintained, but if you turn it off, the movements return, although there may be a delay for that to occur. Next slide. And so what they showed was that the DBS actually improved both dystonia and choreic classical orofacial movements together, and about half the patients were able to stop all their medications that they're using for their tardive syndrome. Next slide. And so this is the last slide. We're back to this again. So, you know, it's an exciting time. We have a lot of different options for treatment if changing the causative drug doesn't work. And we can use our evidence to try things in a particular order with 3 tiers of medications the use of botulinum toxin, and then ultimately, if nothing seems to work, using a surgical approach, which can have a fairly dramatic effect. So I think I'll stop here, Kathleen, and then we can go to questions. Thank you very much for your attention.
Hi, everybody. So we're ready for some questions and answers. I hope you can hear me okay. I seem to be getting some feedback. Thank you, Dr. Factor, for a very informative, fascinating, helpful presentation. We received several questions from our attendees during the presentation. Let me go ahead and ask you. So, from anecdotal evidence, tetrabenazine seems to have a much lower efficacy rate. Do you have results from any study more recent than 1999?
No, that actually was the last study, which showed about a 50% improvement in patients. So that's kind of where it stands right now. It would be nice to do a comparative study with the newer drugs, but we just don't have that yet.
Okay. The next question is, I started experiencing vocal tics preceding my withdrawal from Klonopin. Although it has waxed and wanes, I still have this awful syndrome. Doctors I have seen mostly invalidate TD can be caused by benzos. What is your take on this?
I'm sorry, I was having a little trouble hearing you there.
Okay.
So which is the medication that the person asked about?
The person was on Klonopin, and
Okay.
they began experiencing vocal tics preceding their withdrawal from Klonopin.
Yeah.
It has waxed and waned for them. Doctors that I've seen mostly invalidate TD can be caused by benzos. What is your
Yeah.
take on this?
Yeah, I agree that benzos usually do not cause tardive dyskinesia. There are very rare descriptions of movement disorders caused by benzos, but for the most part, we actually use them, especially Klonopin, to treat movement disorders, including Tourette syndrome, including tardive syndromes. And so usually clonazepam is not thought of as a cause of tardive syndrome, and it doesn't have effects on dopamine receptors.
Okay. The next question addresses respiratory dyskinesia.
Right.
This person has been struggling with it for 3 years. She has not had improvement on Xanax or anafranil. What is your what would be your opinion of the best treatment for respiratory dyskinesia?
Yeah, so respiratory dyskinesia, for those people who don't know what that is, it's when you have involuntary movements of your diaphragm, and so you don't breathe in a normal fashion. And we see that there's a part of classical tardive dyskinesia can have respiratory dyskinesia. We see it in Parkinson's as well. Patients have levodopa-induced respiratory dyskinesia. And the treatment for respiratory dyskinesia in tardive syndrome is the same as what we would do for the classical form, trying VMAT2 inhibitors first, and then going on to the second and third tier drugs. And if it's very severe and not responding, then I would probably recommend deep brain stimulation for that. Amantadine might be a particularly useful drug in this case because in Parkinson's disease, it helps respiratory dyskinesia caused by levodopa. So that might be an option.
The next question is, doesn't Keppra sometimes cause mania?
Keppra can, on rare occasions, cause a variety of behavioral side effects. So yes, you have to be careful with that. Usually we start at a very low dose and we kind of build it up to make sure that people can tolerate it. But of many of the anti-epileptic drugs out there, Keppra is actually one of the better tolerated drugs. But yes, you have to be careful with that.
Okay, as someone who suffers from and advocates on akathisia, we are seeing many of our members who have developed often multiple tardive disorders, a mix of akathisia, dyskinesia, Parkinsonism, Tourette dystonia, from antipsychotics, SSRIs, and benzos, and they struggle to get a formal diagnosis from psychiatry or neurology. Many are misdiagnosed with functional neurological disorder, and the Ames or the Barnes scale are not regularly not given. Does your expertise and excellent presentation, could you comment on why FND appears to be default diagnosis in many cases, and how many patients might better advocate for tardive syndrome diagnosis?
Well, we see FND as well in our clinic, and they are fairly common as well. But tardive, drug-induced movement disorders are quite varied, and sometimes that variation can really confuse a clinician who doesn't have a lot of experience seeing these patients. And sometimes if they're not familiar with an unusual feature, they might tend to call it something that's functional. It's very important for you to see a movement disorder specialist with experience in both of these disorders so that they could make an appropriate diagnosis. Functional disorders are a very serious problem. And, part of the reason for this question of overlap in diagnosis is that often both are associated with concomitant psychiatric ailments like depression and anxiety. And that might be part of the reason as well.
Our next question is, are CBD and THC effective for tardive syndrome? If there has not been any study, would you share your thoughts from your clinical experiences with patients who use CBD or THC to self-treat the symptoms?
So this is a question I get every day in clinic with every disease I see. Should they use CBD? There really is, as far as I know, there's no evidence out there at all. There have been no trials. There are beginning to be some. I've seen some trials in Parkinson's disease actually with CBD. One of the things that concerns me is that these are psychoactive drugs, and many people who have tardive syndrome are already on psychoactive drugs, and they can cause a number of psychiatric side effects in Parkinson's disease. We've seen patients actually develop psychosis with hallucinations and paranoia. And so, until there's enough information out there, I usually don't recommend that people utilize CBD or THC for this. There probably will be some studies regarding anxiety for this. And I've actually spoken to, as many of you know, there's a form of CBD that's FDA approved for epilepsy that's used. And, I've asked them about whether they have any intention of studying Parkinson's disease or tardive dyskinesia or other movement disorders. And these diseases aren't even on their radar for use. At this point, they're using it mostly for epilepsy, anxiety. There's even a trial on brain tumors with CBD. But I think at this point, the better track to take would be prudence, because these are psychoactive drugs that do have side effects.
Okay, well, we have run out of time, but we will forward any further questions to Dr. Factor, and he's graciously said that he will respond to us, and we'll get the message back to you. So I just want to say thank you for attending our webinar today. thank you to the volunteers who have made this possible today. If you would like to view this presentation at a later date, please visit our website, pdhealth.org. We want to thank Teva Pharmaceuticals for making a financial contribution to make this webinar possible. And please consider making a donation at our website to help us continue to raise awareness of Tardive syndrome. Thank you very much.
Kathleen, if I might, I want to
Yes.
thank you for inviting me to speak. And I want to thank you for starting this organization, something that's been needed for a really long time. And I'll be sure to send my people to your website, and hopefully the word will spread.
Thank you very much, Dr. Factor. It's been a pleasure hearing your presentation today. We thank you very much.
Thank you. And also want to remind everyone to please take the survey that will launch at the end of this webinar. Okay. Thank you and have a great day.
Thank you, everyone,
you.
for joining us.
Thank you.